Welcome to the deep dive. Ever wonder how your body keeps its fluids, perfectly balanced?
It's a pretty complex system.
It is. And today we're diving into what happens when that balance goes wrong, specifically with SIADH syndrome of inappropriate antidiuretic hormone. We've got some medical texts to guide us.
Right. SIADH, it's basically a situation where your body just holds on to too much water, stubbornly.
Even when it doesn't need it.
Exactly. And it's because this hormone, ADH, also called vasopressin, it gets released when it really shouldn't be.
Okay, so ADH, that's normally the hormone telling our kidneys how much water to conserve,
Right.
right? So what's the big deal if it's overactive?
That's the key. In a normal feedback loop, the signals that usually say, okay, ADH, calm down, they just aren't working properly in SIADH.
Oh.
So the result is water retention. And all that extra water dilutes your blood.
Making the sodium levels drop.
Precisely. That's hyponatremia. Plus, you get this increase in fluid volume outside the cells.
So what causes this? What makes the ADH go haywire? Our sources mention a few culprits.
They do. A big category is issues within the central nervous system. Things like infections, meningitis is one example,
Okay.
head trauma, brain tumors, even recovery from intracranial surgery.
Yeah.
Anything messing with the brain's regulation center.
That makes sense, the brain being command central. Anything else outside of direct brain issues?
Yes, definitely. Certain medications are on the list too. Some analgesics, so pain relievers, barbiturates, which are sedatives, and even some chemotherapy drugs can trigger it.
Interesting.
And the texts also note a less common cause, mainly in kids, if they're being treated for the opposite problem, AVPD, or central diabetes insipidus,
Right.
and they accidentally get too much vasopressin treatment. That can swing them into an SIADH state.
Okay, got it. So causes are varied. Now let's talk symptoms. If someone has SIADH, what are the signs? What would a nurse or doctor be looking for?
Well, from a nursing assessment standpoint, you start with the patient's history. Any of those CNS issues we mentioned?
Infections, tumors, surgery, trauma.
Exactly. Or are they on those specific medications? Or do they have that AVPD treatment history? Then you look for observable signs,
Like what?
like decreased urine output is a big one. Maybe some weight gain that isn't explained by eating more.
Okay.
And sometimes GI issues crop up, loss of appetite, nausea, maybe vomiting.
And I imagine the low sodium must cause brain-related symptoms too.
Oh, definitely. That's often the most concerning part. As that sodium level drops, you start seeing neurological changes.
Such as?
It can range.
Yeah.
Lethargy, just feeling really tired or sluggish. Behavioral changes. Headaches are common.
Okay.
Then, as it gets more severe, you might see altered consciousness, confusion, and in the worst cases, seizures or even coma.
Wow. So that low sodium is serious business for the brain.
It really is. Brain cells are very sensitive to those sodium shifts.
So how is SIADH actually diagnosed then? What do the tests show?
The key tests are blood and urine analysis. In the blood, you'll typically find that low sodium level we talked about.
Hyponatremia.
Correct. And low serum osmolality, which basically means the blood is too dilute, not concentrated enough.
Makes sense with all the extra water.
Exactly. And because everything's diluted, you might also see lower levels of urea, creatinine, uric acid, and albumin in the blood.
But the urine is different. I gathered that from the name Inappropriate ADH.
Yes, the urine tells the opposite story. Even though the body is waterlogged, the urine is paradoxically concentrated.
How so?
You'll find high urine osmolality, it's packed with solutes, high sodium concentration in the urine, and a high specific gravity, usually over 1.030.
Specific gravity. That's like the density of the urine.
Sort of, yeah. It reflects how much stuff is dissolved in it. High specific gravity here means the kidneys are holding on to water like crazy and just putting out concentrated waste.
Gotcha. Do they do other tests?
They might check adrenal, thyroid, and kidney function just to rule out other conditions that can sometimes cause low sodium. Make sure it's really SIADH.
Now, the sources drew a comparison with AVPD, central diabetes insipidus. Can we clarify that? Sounds like they're polar opposites.
They really are. It's a helpful comparison. A good way to think about it is SIADH is low and wet.
Low sodium, wet from water retention.
Exactly. And AVPD is high and dry.
High sodium, dry from dehydration.
Perfect. So let's break it down. Urination in SIADH is decreased. In AVPD.
Increased. Way increased, right? Lots of dilute urine.
Correct. Blood sodium,
Yeah.
low in SIADH, high in AVPD. Serum osmolality, low, under 280 usually in SIADH.
And high, over 300 in AVPD.
You got it. Urine-specific gravity.
High.
over 1.030 in SIADH versus very low, less than 1.005 in AVPD.
Because the kidneys can't conserve water in AVPD.
Right, and urine osmolality reflects that too high in SIADH, low in AVPD. Symptoms follow suit. Fluid overload, weight gain, maybe high blood pressure in SIADH.
Just versus dehydration, intense thirst, weight loss in AVPD.
Precisely. Knowing one helps understand the other.
Okay, that contrast is super helpful. So how do they manage SIADH? What's the treatment?
Well, the first step is always to try and treat the underlying cause, if possible. Fix the infection, stop the offending drug, address the tumor.
Makes sense.
But symptomatically, fluid restriction is usually the main treatment. Limiting water intake helps the body correct the dilution.
How much restriction?
It varies, but it can be quite significant. And if the hyponatremia is severe or causing symptoms, they might give intravenous sodium chloride, usually a hypertonic saline solution, carefully, to raise the blood sodium and osmolality.
Okay. And what about the nursing care side? What are the priorities?
The big goals are restoring that normal fluid balance and preventing injury.
Yeah.
Especially with those potential neurological symptoms.
Right. The confusion, seizures.
Exactly. So safety precautions are key. Keeping the bed low, maybe padded side rails if seizures are a risk, closely monitoring mental status,
What else?
reporting any headache or increased irritability quickly, as those can be early signs of worsening hypernatremia. Strict monitoring intake and output is crucial. Daily weights.
To track fluid status.
Yes. Sometimes a urinary catheter is needed for really accurate output measurement. And helping the patient cope with that tough fluid restriction is important too.
How do they do that?
Offering sugarless hard candy to suck on, frequent mouth care, maybe a wet washcloth for the lips, sometimes measured amounts of ice chips instead of liquids, and of course, administering any prescribed electrolyte replacements carefully.
Got it. So wrapping up, SIADH is essentially the body holding on to excess water because ADH isn't being regulated properly, leads to low sodium, a range of symptoms, often neurological.
Yeah, and it usually stems from some other underlying issues, CNS problems, meds. And remembering it's the opposite of AVPD, low and wet versus high and dry, is a really good anchor point.
It really is. It's quite something how a single hormone acting inappropriately can cause such widespread effects.
Absolutely. It just underscores how incredibly fine-tuned our body's internal balance normally is. This delicate dance of hormones and electrolytes.
It's a great point to end on, thinking about that delicate balance. Thanks for breaking down SIADH with us today.